What's up, Ninja Nerds? In this video today, we're going to be talking about lipid disorders. There's a lot of different types of terminology that we have to get down, so let's go right through that first. So first thing, when you have a patient who has lipid disorders, there's different ways that you can describe it. Do they have dyslipidemia? Do they have hyperlipidemia? Do they have hypercholesterolemia? Or do they have hypertriglyceridemia? Let's quickly define these and then go through the pathophys and some of the causes behind these different types of lipid disorders. So first thing, when we define dyslipidemia, it's an abnormal concentration of specific types of cholesterol or lipoprotein molecules. And you know what those are? So an abnormal concentration of LDL and HDL in the blood. You know, generally we refer to as LDL, that low density lipoprotein, is the one that contains lots of cholesterol. That's the bad one. That's the one that's responsible for leading to atherosclerosis. So in dyslipidemias, there's an abnormal concentration of LDL. Usually it's increased. And then the other one is HDL. This is often referred to as the good cholesterol, the high density lipoprotein. Pulls some of the actual plaque and cholesterol away from the actual vessel walls. And so in this situation, there's an abnormal concentration of this where there's less of the good cholesterol. So in dyslipidemias, it's an abnormal concentration of LDL and HDL where there is an increase in LDL and a decrease in HDL. The other one is hyperlipidemia. Now, hyperlipidemia is when there is an increased concentration of lipids inside of the actual bloodstream. And that includes an increase in LDL and an increase in triglycerides. And so in hyperlipidemia, there is an increase in LDL and an increase in triglycerides. That's your hyperlipidemia. The next one is hypercholesterolemia. That's pretty straightforward. It's an increased total concentration of cholesterol molecules. So all the cholesterol molecules, generally, we say when the total cholesterol is high, particularly how high? Greater than 200 milligrams per DL, we consider that to be hypercholesterolemia. And generally that's an increase in LDL, an increase in VLDL, and there's generally a lower HDL in a total hypercholesterolemia type of picture. And the last one here is hypertriglyceridemia. Hypertriglyceridemia, it is an increase in the total number of triglycerides. Generally, when we say that this is whenever it's greater than 150 milligrams per DL, but it can get a lot higher, okay? So that would be your hypertriglyceridemia. So we got down the different terminologies. Abnormal concentration of LDL and HDL, dyslipidemia. Increase in the LDL and triglycerides, hyperlipidemia. Increase in total cholesterol, hypercholesterolemia. Increase in the triglycerides, hypertriglyceridemia. Done. Okay, the next thing that we have to talk about is a little bit about the physiology of the lipids, okay? Because if we understand the physiology, we can easily understand the pathophysiology and the causes behind these diseases. So first things first, when we're actually taking and eating particular types of fatty substances that contain cholesterol, contain fats, how does those actual molecules get absorbed across the GI tract and eventually get into the bloodstream? It's a great question. You know, our gallbladder will make a particular molecule called bile. And the gallbladder will squeeze out a different component of the bile called bile acids. And the bile acids will bind with the free fatty acids, bind with the cholesterol, and make these molecules here called micelles. And micelles will get absorbed across the GIT and into the lymphatic circulation. So you see this green vessel here? That's your lymphatic circulation. When they get absorbed across the GIT, they get packaged into these new molecules here, these new lipoproteins called chylomicrons. Chylomicrons are lipoproteins that carry a ton of triglycerides and a little bit of cholesterol, but a ton of triglycerides. What they do is eventually they get their way into the actual blood, the vascular system, via like the thoracic ducts. You have the venous, we generally have what's called the venous circulation, and you have the lymphatics that dump into them. Once they get into the blood, they travel through the blood, and there's specific enzymes in the bloodstream that can actually work and metabolize those chylomicrons and rip out of them free fatty acids to be taken up into adipose tissue and muscle tissue. And this is called lipoprotein lipase. So it'll rip out some of the triglycerides and break them down into free fatty acids to get taken up by muscles and adipose tissue. And then afterwards, it'll become what's called a chylomicron remnant. And that'll get taken up by the liver via these different types of receptors. The liver will then take the chylomicron and take some of the cholesterol from that and make another molecule called VLDL, very low density lipoproteins. These VLDLs are carrying a ton of triglycerides and a little bit of cholesterol, just like chylomicrons. They move through the bloodstream, they're acted on by the lipoprotein lipase, who will break some of the triglycerides out of there and release some of these as free fatty acids to get taken up by the muscle, taken up by the adipose tissue, just like the chylomicrons. What's remaining from the VLDL is a lot of cholesterol within them and less triglycerides. And what happens is some of them will get taken back up into the liver cells by these different receptors, but a good chunk of them will turn into something called LDL. LDL is the one that contains a lot of cholesterol and very little bit of the triglycerides. What the LDL will do is it'll take and deposit some of that cholesterol into various tissues. And one of the problematic issues is it can lead to atherosclerotic cardiovascular disease. It can deposit a lot of fat into the vessels, which leads to these big fatty plaques within our vessels. The other thing is, once the LDL can do that, it can also take and bring some of the cholesterol back to the liver, where it binds onto these things called LDL receptors to help to bring some of the LDL back into the actual liver, and it'll use some of the cholesterol to make more lipoproteins. Last but not least, we have this other protein here called HDL. HDL is a protein, a lipoprotein that's made by the liver. And in this form, it's called the nascent HDL, meaning it doesn't have much fat within it. It just has a lot of lipoproteins. And what happens is, it's so cool because it's that good type of lipoprotein where it comes and removes. So you see how it doesn't have any kind of cholesterol within it. It's just a protein with different types of little molecules on it. It'll go through the vasculature and rip part of the actual plaque and cholesterol out of this actual vessel wall and pick it up. And it'll remove plaque and take all of that actual cholesterol from the plaque and take it back to the liver and bind onto this HDL receptor. So that's why it's good at removing plaques, while LDL is adding to the plaques. Now the question is, when someone has these different types of lipid disorders, where they're either having an increase in their LDL, an increase in their triglycerides, an increase in their total cholesterol, a decrease in their HDL, what's leading to these problems? That's the question. And oftentimes it's either inherited or familial or acquired causes. Let's talk about the familial ones. We're not going to go into crazy detail about these. We talked about these usually in step 1. And this usually is called the Frederick classification. And there's different types. So type 1, type 2A, type 2B, type 3, and type 4. And in this condition, they have an increase in the number of chylomicrons because there is a defect in the lipoprotein lipase. It's not working. So it's not actually ripping apart the actual the triglycerides and converting them into free fatty acids. Or the chylomicron receptor, which is supposed to take it into the liver, isn't doing that. And so there's an increase in the number of chylomicrons in the blood. What do chylomicrons carry a lot of? Triglycerides. And so in this disease, they would have a lot of triglycerides within their blood. The other one is a type 2A hyperlipidemia. In this situation, they have a ton of LDL molecules. And the reason why is, in type 2A, this receptor, the LDL receptor, is defective. It's not taking up the LDL molecules. If it doesn't take up the LDL molecules within inside of the blood increase, and they increase the deposition of cholesterol into the vessel. And that's a problematic issue in this disease. In type 2B, which is just like this one, it's the same exact issue. Their LDL receptor is downregulated, or it's not present as much. And so because of that, they can't bring up the LDL into the actual liver cell. And so what it makes it seem is though the actual liver needs to increase its production of lipoproteins. And the one that it actually produces a lot of in response to that is VLDL. So it increases or amps up the VLDL production. And so in type 2B, there's a defect in the LDL receptor, which causes a increase in LDL within the blood because you're not uptaking it into the liver. And then the liver responds to that not having a lot of LDL uptake and makes more VLDL. The next one is your type 3. And what happens here is there's an increase in your chylomicrons or an increase in the VLDL. The reason why is there's a specific protein on the chylomicrons called an ApoE, and it's the same kind of protein on the VLDL. There's a defect within the actual ApoE protein where the VLDL and the chylomicrons can't get uptaken into the liver. So you build up chylomicrons and build up VLDLs in the blood. What do chylomicrons and VLDLs carry a lot of? Triglycerides. So this disease would be characterized by a lot of triglycerides. And the last one is type 4. In this one, the liver just makes too much VLDL. And so if it's amping up the VLDL production, what does VLDL contain? Primarily triglycerides. And so in these diseases, they'll have a lot of triglycerides within the bloodstream. So this is your inherited causes or the familial causes for these types of lipid disorders, okay? What about the acquired causes? What are the things that can alter the LDL, the triglycerides, the HDL molecules in the blood? Let's talk about that. All right, so the next thing here is when we talk about acquired causes, what are some particular reasons why you can actually develop an increase in LDL or VLDL or triglycerides and a decrease in HDL, all of those different things in acquired causes, so things that you weren't actually born genetically with. So one would be diabetes. This is a big one. Reason why in diabetes is generally insulin works on that enzyme called lipoprotein lipase. Remember what that does? It takes things like VLDLs and chylomicrons and rips out what things? It rips out the triglycerides and converts them into free fatty acids, which can get taken up by the muscles and broken down for energy or into the actual fat tissue and made into fat. And so that's the function of it. In patients who have diabetes, there is an issue with their insulin resistance. The lipoprotein lipase is not responding as well to the insulin. So because of that, there is a decrease in the activity of the lipoprotein lipase. That means that it's not converting as much of the actual triglycerides from the VLDLs out into free fatty acids. So you're not doing this as much. Because of that, the VLDLs are retaining all of those triglycerides. And so what happens to the triglycerides within the blood? It goes up because of the increase in VLDLs. And the other thing is VLDLs eventually get converted into LDLs. And so if you have lots of VLDLs, there'll be an increase in conversion to LDLs. And so there'll also be lots of LDLs within the molecule, LDL molecules within the blood, increasing your cholesterol. So in this situation where a patient has diabetes, it can increase their VLDLs and increase their LDLs. And that again can lead to this type of dyslipidemia, abnormal issues here. Okay, with hypothyroidism. In hypothyroidism, what happens? Normally thyroid hormone works to particularly act on the liver and work to upregulate these LDL receptors. Why is that important? Because you know LDL, when it's in the blood, what is it actually doing? It's depositing different types of plaques within the tissue, depositing cholesterol within the tissues. Afterwards, it'll go back to the liver. The liver will uptake the actual LDL. It'll uptake it, and then generally will make different types of lipoproteins. For example, it'll make like VLDL, right? Well, what happens is if your T3 and T4 levels are low, you can't work to upregulate those LDL receptors. So now they're downregulated. You don't have these. The LDL molecules, after they're done, are supposed to get taken up by the liver, but they don't. They stay in the bloodstream. And so your LDL levels will rise and rise and rise. And that's one of the particular problems with hypothyroidism. The other one is called nephrotic syndrome. So in nephrotic syndrome, they generally lose a lot of albumin in the actual urine because of their damage to their kidneys, their glomeruli. Because they lose a lot of albumin inside of their urine, what happens to the albumin inside of the blood? There is a decrease in albumin in the blood. Now, you know what albumin does? Albumin carries fatty acids, free fatty acids. And so what happens is this reduction in albumin tells the liver, hey, there's not enough albumin. You need to make a lot more albumin proteins and other kinds of similar proteins. And so the liver doesn't know any better. And so it starts making lots of proteins. It makes more albumin as a response to a decrease in albumin because you're peeing it out. But guess what else it makes a lot of? What's one of the lipoproteins that it makes a lot of? VLDL. It's a protein and it increases the concentration of the VLDL within the blood, which increases the triglycerides within the blood and the cholesterol within the blood. Again, donating its effect to these different types of lipid disorders. All right, the medications, there's not a lot of literature out there to suggest how exactly they alter our particular lipid biochemistry, but I think one of the big things is to remember the most common medications that they could present on the exam, and I bet you'll actually remember these now, because beta blockers, estrogen-containing oral contraceptives, and thiazides have been shown to potentially increase the actual lipid profile, particularly increasing LDLs, increasing VLDLs, and decreasing HDL molecules. Mechanisms we don't really know too well, and I don't think it's actually worth noting. Don't forget those. The last thing here is probably one of the easiest ones to remember: increasing weight, increasing diet that's high in cholesterol, high in triglycerides. Think about it. If you have a patient who is eating a ton of cholesterol, right? They're just downing like, Big Macs, or lots of fats within their diet. They're increasing the absorption of these fats into the actual bloodstream via the chylomicrons. That's increasing the uptake into the liver. That's making more VLDLs, making more LDLs. So by virtue, increasing the cholesterol and fat within inside of the bloodstream can increase your chylomicrons, your VLDLs, and your LDLs. When you have an increase in weight and decreased exercise, a patient who has a sedentary lifestyle, you know what that does? A sedentary lifestyle actually decreases the production of your HDL molecules. If you don't have as many HDL molecules, can you rip the actual cholesterol out of the plaque wall? No. And so you have less of these HDL molecules that you're taking back to the liver and removing plaques from the actual vessel wall. And that can increase the risk of forming these atherosclerotic plaques because you don't have the HDL to rip away the cholesterol from the plaque wall, from the actual vessel wall. And so that's an important thing to remember. All right, now let's move on to features and complications. All right, so you have a patient who has a lipid disorder, whether it be due to a familial, whether it be due to an acquired cause. They have a lipid disorder, they have an increase in LDL, an increase in the triglycerides, a decrease in the HDL, and it's causing all of these different problems. What will that look like in the clinical vignette? Generally, one of the big things is skin manifestations. So they can present with these things called xanthomas. It's a lot of this cholesterol and triglyceride deposition into the actual skin tissue that produces these very interesting types of skin manifestations. So when I talk about xanthomas, there's three different types that I want you to remember. One is these eruptive xanthomas. They're kind of like these yellowish papules with an erythematous border that you generally see on things like the buttocks, the back, and maybe extensor surfaces. They look like this. All right, the other one that I want you guys to remember is something called a tendinous xanthoma. So tendinous xanthomas are these kind of like firm, nodular types of appearances that can appear on tendons. What tendons are the most common? The extensor tendons of the hand and the Achilles tendon. They look like this. And the last type of xanthoma that I want you guys to remember is a tuberous xanthoma. These are also yellowish, kind of like nodules with an erythematous border, and they usually appear kind of across joints, most commonly like the elbow and maybe even the knees. They look like this. All right, so that covers the xanthomas. The other skin manifestation that I want you guys to remember, sometimes you can get a lot of fatty plaque development around the nasal portion of the eye, and this is called xanthelasma. It looks like this. All right, the other thing that I want you guys to remember is the eye. So generally, you have the iris, and right around the edge of the iris, you can get kind of this big brown fatty deposition around the edge of it, and it's called a corneal arcus. It looks like this. All right, the other thing that I want you to remember is if you get a lot of lipid and triglyceride deposition, cholesterol deposition into the liver, it can actually cause the liver to become very, very fatty. And this is called hepatic steatosis. It can actually lead to complete cirrhosis of the liver. So remember that. It's called a non-alcoholic fatty liver disease that can actually be very, very devastating. And the last one that I want you guys to remember is the pancreas can be significantly affected whenever you have super, super high triglyceride levels. And how high am I talking? I'm talking triglyceride levels greater than 1,000 milligrams per DL. If you have triglycerides greater than 1,000 milligrams per DL, it's really at high risk of producing pancreatitis and acute inflammation of the pancreas. So don't forget that. All right, so now that we got the classic clinical features that you can see in these, the last one is the big one, the scary one, the ominous types of things that you can see from these lipid disorders. We've kind of hinted to this, but as you have high levels of LDL, high levels of triglycerides, and decreasing levels of HDL, you increase the deposition of cholesterol and fat into the actual vessel walls, leading to atherosclerosis. As you cause atherosclerosis of particular vessels that supply different organs, you may see organ dysfunction because you have to try to squeeze oxygen and nutrients through that tiny little arrow there, okay? Now, think about the particular organs that could be affected. Think about the carotids. You develop a big old chunky plaque within the carotids, and I'm supposed to be able to deliver as much oxygen as I can to my internal carotid artery, which supplies my brain. Oh man, you can definitely end up with some particular issues there, some carotid artery stenosis, especially if the stenosis is greater than 70%. The other thing is, If I develop a lot of plaques within the smaller vessels in my brain that supply different types of brain tissue, and I don't supply enough oxygen to the tissues because of these plaques, I can develop with an infarct. So I can develop things like a cerebral vascular accident. So remember, in patients who can have these plaques, they're at high risk of carotid artery stenosis, which can present with a TIA, or can present with a cerebral vascular accident, a complete infarction of the tissue, a stroke, if you will. The other thing is, what if I actually develop this kind of plaques within the vessel walls of the actual coronary vessels, and I don't supply an adequate amount of oxygen to the actual myocardial tissue? Then it can lead to an infarct, which is called a myocardial infarction. Or you can just have very little oxygen supply to the tissue, but it doesn't actually infarct. That's coronary artery disease, where they can have like an anginal chest pain, but no true infarction or death of the tissue, just ischemia to the actual myocardial tissue. And the last one here is peripheral artery disease, particularly of the lower extremities. So whenever you have your aorta, it gives these branches off, right? You have like your common iliacs would go into the femoral, the popliteal, the tibial, all of those. Sometimes if you have a plaque within inside of these vessels and you can't get oxygen or nutrients to the actual muscles surrounding these areas, you can have these muscles become very, very, very painful whenever you're trying to walk or exert yourself. And this can cause claudication, right? That's the pain whenever you're trying to exert yourself. Sometimes if the plaques are so bad that you rupture the atherosclerotic plaque and develop a clot on top of that, you can develop an acute limb ischemia where you have no blood flow to the limb and the actual limb can die. And that's one of the other issues that you can see with this disease. All right, so we understand the features and the complications. Now let's move on to the diagnosis and treatment. All right, so when we talk about the diagnosis, oftentimes it just includes getting a lipid panel. And within a lipid panel, you'll get like your total cholesterol, you can get your LDL, your HDL, and you can even get some triglycerides. So whenever we get a lipid panel, we should obviously determine someone's risk of developing the complications that we discussed, such as atherosclerotic cardiovascular disease, because when we get a lipid panel, it can determine our need to say, okay, you need to start doing some of these particular medical managements. And so when we take a lipid panel, what are the numbers that should actually concern us? Well, total cholesterol, again, that takes into consideration LDL, VLDL, HDL. Whenever the total cholesterol is greater than 200 milligrams per dl, that's slightly concerning. But whenever it's greater than 240, that's definitely very high and very concerning. I would say one of the most important ones, and it's the most specific one because it's the one that we look at as the most remarkable one, the one that causes a lot of the pathology, is LDL. So whenever LDL, the low density lipoprotein, that bad cholesterol, is greater than 130 milligrams per dl, that's pretty high, but it's like in that borderline. Whenever it's greater than 160, it's high. And whenever it's greater than 190, it is very high and very, very concerning, okay? HDL is that good cholesterol, so you don't want to have little of it. You want to have a decent amount of it. So generally, whenever we have patients who have less than 60 milligrams per dl, we say that that's a lower HDL, and that can also increase the risk of having plaques. Because again, remember what HDL does. HDL helps to potentially remove some of the actual cholesterol from the plaque within those vessels. And so having lower amounts of that is also disastrous. The triglycerides is really dependent upon diet. So whenever you have, or some type of familial hypertriglyceridemia. So whenever patients have very high triglycerides, you can either, usually say it's dietary or it's a familial problem. So generally whenever we say it's greater than 150, that's, pretty high. Greater than 200 is very high. And then usually whenever it's greater than 500, you're at risk for a lot of problems in these situations. So we consider this to kind of be like borderline, high, and then very, very high. All right, so these are the things that I want you guys to remember. So if I had a patient who had a total cholesterol greater than 200, that's concerning. An LDL greater than 130, greater than 160, greater than 190, that's concerning. If I have an HDL less than 60, that's concerning. If I have a triglyceride greater than 150, concerning. Even greater than 200, more. And greater than 500, super concerning. Now, with that being said, if we have a patient who has some concerning signs, let's say for example, they have a super high LDL of 190, what are the particular medications that I could prescribe this patient to try to effectively lower their LDL and prevent them from developing the complications such as atherosclerotic cardiovascular disease, skin deposition, eye problems, hepatic steatosis, etc. Let's talk about that now. All right, so when we talk about these medications, it goes back to the physiology. If you guys remember all the physiology, the medications are actually going to be pretty simple. So if you guys remember, we have the liver, right? The liver is where we're kind of synthesizing a lot of these lipoproteins. And it's primarily that VLDL that we actually want to remember, right? So The way it does that and makes those VLDLs is it incorporates triglycerides and cholesterol, puts it in a protein package, and then puts it into the bloodstream. Well, the question is, where did that cholesterol come from? That's a great question. It comes from this molecule called acetyl-CoA. So acetyl-CoA will actually get converted in through a significant mechanism where we're not going to talk about, but it goes through a process of like these biochemical pathway where it becomes HMG-CoA. HMG-CoA then through another set of mechanisms gets converted into cholesterol. And that cholesterol, when it combines with triglycerides and things of that nature, it makes these molecules called VLDLs, these lipoproteins. And then we know that VLDLs will eventually become LDLs, which is the problematic molecule. So because of that, how do I lower the cholesterol, effectively lowering my VLDL, effectively lowering my LDL? That's a great question. If I can give drugs that work on that enzyme and potentially help to inhibit this enzyme, then I won't be able to perform this step. I can't make any cholesterol. There'll be a decrease in cholesterol, a decrease in VLDLs, and a decrease in the LDL. What kind of wondrous drugs would do that? These are HMG-CoA reductase inhibitors, and that drug class is called your statins. Now, I didn't write every single drug because we're going to talk about those later, but you can remember them by the mnemonic. Real Americans still love playing football. So that's rosuvastatin, atorvastatin, simvastatin, lovastatin, pravastatin, and fluvastatin. These are your statin drugs that are HMG-CoA reductase inhibitors. And again, they work to be able to lower your VLDL, which will lower your triglycerides a little bit, and lower your LDL. Pretty cool, right? All right, that's the next one. Now, we make this VLDL, and this VLDL gets put out into the bloodstream, right? Once the VLDL gets put out into the bloodstream, and remember it gets acted on by this enzyme here called the lipoprotein lipase. You guys remember that? What did the lipoprotein lipase do? It did two things, right? It broke down the triglycerides from the VLDL into free fatty acids, which can get taken up by adipose tissue and muscle tissue. From VLDLs, but what else did it do it from? The chylomicrons. The chylomicrons, which came from your GIT, containing a lot of triglycerides and a little bit of cholesterol, it also got metabolized by the lipoprotein lipase, broke down the triglycerides and released out the free fatty acid to get taken up by the adipose and the muscle tissue. If I had a drug, if I ever had a drug that could potentially do what? Stimulate the living crap out of the lipoprotein lipase and stimulate this lipoprotein lipase here. If I increase the activity of this enzyme, I would effectively break down more triglycerides. So I'd have less of the actual triglycerides within these chylomicrons. I would release more free fatty acid, get taken up by the muscle, get broken down, or get taken up by the liver and stored as fat. But there'll be less triglycerides within the bloodstream, right? That would be a great thing. So giving fibrates like fenofibrate and gemfibrozil, what they do is they increase the lipoprotein lipase activity, which helps to effectively break down more of the VLDLs and break down more of the chylomicrons, which effectively lowers your triglyceride levels. This is a drug that's been shown to potentially be relatively effective at lowering triglyceride levels more so than LDLs. But it actually, if you lower VLDLs, you'll lower your LDLs as well. But this one more significantly lowers your triglyceride levels. All right, so that would cover your fibrates. Now, let's say that you had the VLDL molecules, right? Eventually they get converted into LDLs, right? Because you know it'll actually take the triglycerides, get broken down by the lipoprotein lipase into free fatty acids, and then it'll contain a lot of LDL molecules, which has a lot of cholesterol. And that's a problematic issue because it deposits a lot of that cholesterol into the vessel walls and leads to the athero, which we see as the complications here. The other thing is that the LDL molecules will get taken up by this LDL receptor, right? And get taken into the actual liver cell. The liver cell will then use the cholesterol from the LDL to make more types of molecules. It may make more VLDLs, it may help to be able to make a lot of different things, cell membrane components, whatever. But either way, that cholesterol will get taken up into the liver cell. Now, what if there was a way, because you know what happens with LDL receptors? Naturally, sometimes is we take LDL receptors and we try to downregulate them or degrade them. Okay, so generally once you take the LDL receptor, you take it inside and sometimes they can get degraded. What if there was a drug that could inhibit the LDL receptor degradation and increase the number of LDL receptors? What if I could increase the number of LDL receptors that are expressed on the liver? If I increase the LDL receptors, wouldn't that help to be able to have more receptors for LDL to bind onto? Taking more LDL inside of the actual liver cell, effectively lowering the LDL within inside of the bloodstream. That's where these PCSK9 inhibitors come in. And this would be a drug like evolocumab. Now that is, again, important to remember. All right, so we got our statins, we have our fibrates, we also have our PCSK9 inhibitors, which again work to be able to, two ways. You can think about it like this, either increasing the expression of the LDL receptors or reducing the degradation of them. Either way, you're having more LDL receptors, more uptake of the LDL, less LDL within the bloodstream. Either way, same concept. Okay, the next one here is niacin. Now, what's really interesting here is that whenever you have niacin works to be able to do something very interesting. You see these VLDLs? Niacin can work to be able to inhibit the synthesis of VLDLs. So basically, when you take cholesterol and triglycerides and incorporate them into making a VLDL, niacin can shut that process down. And if it shuts that process down, it'll effectively lower the VLDL molecules, which would lower the amount of triglycerides that you're carrying around in the blood. The other thing here is that niacin has been shown to be able to work here. You know, whenever adipose tissue contains lots of triglycerides, what happens is niacin may also work to be able to inhibit the lipolysis from the fat tissue and basically lowering the amount of free fatty acids which were inside of the bloodstream. And that may lower your total triglyceride levels as well. So whenever we use niacin, the basic thing to remember is that it inhibits VLDL synthesis, so it lowers your VLDL, and it also inhibits the fat tissue from undergoing lipolysis, which reduces the number of free fatty acids inside of the bloodstream. So whenever we use niacin may be good for those patients who have hypertriglyceridemia, because again, it's dealing with the actual triglycerides. Just like fibrates may be a good drug for high triglycerides. All right. The other thing that we have to talk about is come down here to this part. Now you remember we talked about this at the beginning. Whenever a patient is eating cholesterol-containing food, foods that are containing a lot of like fatty acids, what happens is that moves through the GIT. So here we're in the GIT now. Okay, so this is an enterocyte. This is one of the enterocytes for the GIT, and this is the lumen, where all the actual food contents are moving. What happens is cholesterol, which is coming from our diet, will combine with the free fatty acids and then our gallbladder. Remember that made these things called bile acids. Well, bile acids will actually kind of, imagine it kind of emulsifying, coating and covering the cholesterol molecule and the fatty acid and bringing it to the actual enterocyte. Without the bile acids, we can't even get the cholesterol and the triglycerides or fatty acids into the actual enterocyte. Without that bile acids, we can't do that. So what if I had a drug that could potentially work to inhibit these bile acids from binding with the cholesterol, the free fatty acids? If that's the case, then I get less of these packaged things called micelles. That means less of these micelles get taken up into the enterocytes. That means less of the enterocytes make less of these chylomicrons. That means if I have less chylomicrons, what does that do? What does the chylomicrons do? Eventually that'll go to the liver. The liver will have less of the actual cholesterol and triglycerides to make VLDLs, so that'll lower my VLDL, and that'll lower my LDL. So effectively, whenever you have bile acid sequestrants like cholestyramine, it inhibits bile acid activity, which inhibits the absorption of cholesterol and free fatty acids, lowers the amount of chylomicrons, lowers your VLDLs, and lowers your LDLs. This is an interesting drug called your bile acid sequestrants. Now, what about the other thing? What if I just didn't inhibit these? What if I just directly inhibited cholesterol from getting absorbed? So I use drugs that particularly work to inhibit this process, the cholesterol absorption. So now that can't happen. So a drug like ezetimibe. If that's the case, that means I get less micelles, less chylomicrons, less of my VLDLs, and less of my LDLs within inside of the bloodstream. So this is an interesting way where we can inhibit cholesterol absorption directly via ezetimibe, or we can inhibit cholesterol absorption by sequestering the bile acids, so therefore we can't bind the cholesterol and take it up into the actual enterocyte, make chylomicrons, make VLDLs, and make LDLs. Pretty cool, right? So that would be that one. The last one that just as an add-on has been added on recently is fish oils containing a lot of omega-3 fatty acids. There's not a complete understanding of how exactly this particularly works, but it's been shown that these fish oils, these omega-3 fatty acids, have been somewhat effective at being able to lower your serum triglyceride levels. We don't know exactly how, but it might be a beneficial therapy to add on to a patient who has hypertriglyceridemia. So a lot of stuff here that we talked about. What I want to do is I want to take a look at a chart here for a second, go over that quickly so that you guys can see a basic overview of these drugs and what is their primary lipoprotein or molecule that they're targeting to try to lower. Let's talk about that quickly. All right, so we talked a lot about the mechanisms here. Let's just quickly recap these with a nice chart. HMG-CoA reductase inhibitors, your statins, they're inhibiting that enzyme that synthesizes cholesterol. Cholesterol is primarily carried in which type of lipoprotein? LDL. So if we reduce cholesterol, we reduce LDL molecules. Your absorption blockers and your bile acid resins, they inhibit cholesterol absorption into the GIT, across the GIT, and then eventually they reduce the amount of cholesterol being incorporated into LDLs. So they should also primarily drop your LDLs. Your PCSK9 inhibitors, it works to increase the number of LDL receptors by either preventing them from being broken down, but either way, they increase the amount of LDL receptors you have, so you uptake more LDL out of the blood and into the liver. That effectively lowers your LDL molecules. Fibrates are the interesting one because they stimulate the lipoprotein lipase, which helps to break down more of the triglycerides from your chylomicrons and your VLDLs. So that's primarily going to lower your triglycerides. Fish oil, we said, is the interesting one because we add that on as a little bit of way it can reduce the serum triglycerides primarily. And then niacin, or vitamin B3, this is the one that works in two ways. One is it inhibits the VLDL synthesis. If you inhibit VLDL synthesis, you inhibit the actual conversion of VLDLs into what? Into LDL, so you can lower your LDL molecules. Also, you inhibit the lipolysis from the fat tissue, which inhibits the amount of free fatty acids that are being released. And so there is a minor drop in triglycerides as well. So I think the big thing to remember is most of these drugs work to reduce your LDL. The ones that are primarily going to try to drop your triglycerides are going to be your fibrates, your fish oil, and your niacins. The first line is statins. I hope that made sense. All right, let's get back to the whiteboard. All right, my friends, so we finished all about the pharmacology. I know there was a lot, and actually, you know what's unfortunate is the most important one that we actually should remember out of all those is the statins. The statins are the primary first-line medication therapy that we're going to utilize in patients who have high cholesterol, high LDL, high triglycerides. So whenever we talk about these, what are the indications for starting somebody on a particular level of statin? So we have to know this is a high yield for your exam. Do we start this patient on a high intensity statin, and we'll talk about what those are, or a moderate intensity statin that's dependent upon these particular indications? So if I had a patient who had a clinical atherosclerotic cardiovascular disease event, they had an MI, they had a TIA, they had carotid artery stenosis and had a complication associated with that. They have a coronary artery disease and had some type of complication from that, like an MI. Or they have peripheral artery disease or an acute limb ischemia. In those situations, you start a patient on a high intensity statin. The only reason you would do a moderate intensity is if they're really old, greater than 75 years of age, because they may have more side effects from the higher intensity statin. So you may do a moderate intensity statin if they're greater than 75. But if they have clinical evidence of atherosclerosis, you go high intensity. If greater than 75, moderate. The next thing, LDL greater than 190, that's super high. You go straight on a high intensity statin because you're at super high risk for complications. Diabetes, because diabetes is one of the acquired causes and one of the most common acquired causes for lipid disorders, if you have diabetes and you're within the 40 to 75-year-old range, and we'll talk about what this means. There's a particular calculator that you'll utilize, these pooled cohort equations, and you plug a bunch of different things in, it gives you your risk of atherosclerosis and the cardiovascular complications. If that number is greater than 7.5%, high intensity statin, they're at high risk. If they have diabetes, 40 to 75 years of age, and their calculation is less than 7.5%, you're okay with going with a moderate intensity statin. The last thing is, what if they're 40 to 75, don't have diabetes, but their atherosclerotic cardiovascular disease is greater than 7.5? It's a moderate intensity statin. So remember this is super important for your exam. You have to know these. Now the question is what the heck is a high intensity statin and what the heck is a moderate intensity statin? I'm glad you asked. So high intensity statin, there's really two of them. It's rosuvastatin and atorvastatin. So with these, the dosages is what you want to remember. Rosuvastatin high intensity is 20 to 40 milligrams. For atorvastatin, it's 40 to 80 milligrams once a day. For your moderate intensity statins, you can still have the rosuvastatin and atorvastatin. Remember, real Americans still love playing football. In these situations, there's no other way. You just have to memorize the dosages. So take into consideration having to look at these dosages in case you're asked about that on the exam. No other way around that. But this would be your moderate intensity statins and the relevant dosages. Okay. Let's now move on, now that we've talked about that, and talk about the side effects of these lipid-lowering agents, and then lastly, the treatments for your very resistant hyperlipidemia, hypercholesterolemia. All right, so what are the particular side effects that you should know whenever you're putting a patient on a medication? Obviously, statins is gonna be the first line. Obviously, from there on, you can add on different things like the other drugs that we talked about. Those are generally your add-on therapies. With the ones that are more specific for very specific issues, like fibrates and niacin for the hypertriglyceridemia. All the other ones are generally add-on therapies. The side effects to remember here is with CYP450 interaction. So if you're taking other drugs, there's a possibility that those drugs could interact with the metabolism of statins. So remember that other drugs could actually interact or inhibit the CYP450, increasing the effectiveness of the actual statin drugs, causing more side effects. The other thing is hepatotoxicity, so you can have a bump in the LFTs. You see this very specifically with your statins and fibrates. What about myopathy? So you can have actually myalgias, you can have inflammation, sometimes even rhabdomyolysis, where you're popping open muscle cells and releasing things like myoglobin into the actual blood, which can cause acute kidney injury, or releasing CK into the blood, which can cause a lot of CK to build up within the blood. In those situations, you want to think about statins and fibrates. They can cause myopathy, myalgias, and even rhabdomyolysis. The other one is diarrhea. Which were the ones that actually inhibited cholesterol and fat absorption within the GIT? The cholesterol absorption inhibitors like ezetimibe and the bile acid sequestrants, which are working there, the cholestyramine. They'll actually cause you to lose a lot of fat molecules inside of the actual GIT and into the poop, and so you'll have diarrhea in those situations. The last one is niacin. Niacin's an interesting one. So it's been shown that it can increase your blood glucose levels, it can increase the uric acid within inside of your bloodstream, and it can actually increase the production of prostaglandins in the skin, causing vasodilation and fluid leakage into the skin and causing a lot of itching and a lot of redness. And so those are big things to remember for the niacin and all your side effects in general. The last thing to hit at home is if you have a patient who has super resistant lipid disorder, I'm talking they have hypertriglyceridemia greater than 1,000 and you can't get it low. You have a patient with hypercholesterolemia and it's a familial problem, that there's no way that you can control that with medications. Sometimes the best thing that you can do is actually suck the fat out of the bloodstream. You're like, what? There's actually a procedure called an LDL apheresis. If a patient has super high LDL molecules within the blood because they have like a type 2 familial hyperlipidemia, you can literally use this to yank actually some of the LDL molecules out through their circulation, run it through this column and suck all the LDL molecules out, and then send back clean plasma into their actual bloodstream. So that could be one way that you could do this for patients with very significantly resistant hyperlipidemia. The last thing is if they have super problematic issues where they tried LDL apheresis, sometimes you may have to do a liver transplant where they have healthy LDL receptors, because if you have a liver that doesn't have healthy LDL receptors to uptake the LDL, if you give them a new liver that should have LDL receptors, they can take up the LDL molecules and so have less of the actual LDL circulating through the blood. And so sometimes a liver transplant may be the last resort as well. All right, but that covers our lipid disorders. Now let's move on to going over some cases to really put this into perspective.
All right, guys, let's do a case. So we got a 70-year-old male with a past medical history of a TIA, transient ischemic attack, coronary artery disease, hypertension, diabetes, hypothyroidism, obesity, tobacco abuse. Presents to the family medicine clinic to review his recent lipid panel, which a little scared about it. But think about the causes. Again, you guys got the familial ones, the type 1, the type 2, the type 3, type 4, all those, and we talked about those briefly. And then you got all those acquired ones, which I thought was the really important ones. He's got diabetes, that's one. He's got hypothyroidism, that's another. He's also got obesity and tobacco smoking. If you guys remember the other ones was nephrotic syndrome, and then the medications BET, right? Beta blockers, estrogen, and thiazide. So those were a lot of the acquired causes. And then we had the type 1, the type 2, type 3, type 4, familial hyperlipidemias as well. But in this situation here, let's go to the next step here, which is there any particular features, complications? So we do a physical exam and we see xanthelasma. That was one of the findings. That was a lot of that lipid plaques that you could see around there. What else could you see? Xanthomas, right? Does he have any xanthomas? He has tendinous xanthomas. So we can see those along the Achilles tendons or some of the extensor tendons. The other ones were the tuberous xanthomas and the eruptive xanthomas. Remember, the tuberous was across joints like the elbows and the knees, and then eruptive was over in the back, the buttocks, and usually those are the ones that are also kind of more of the puritic type of ones as well. All right, so that's the big thing for him. What else can we do here? We look at his lipid panel. He didn't have any of the other particular things that we were worried about, like pancreatitis, or does he have any hepatic steatosis? We'd have to look a little bit later to see, but we don't know. And the other thing is he had clinical atherosclerotic cardiovascular disease. He had a TIA. He had coronary artery disease. So because of this, he's had clinical ACAVSD. He also has xanthelasma. He has xanthomas. Whew, this guy's all messed up. We get a lipid panel and oh my gosh, total cholesterol 250. This guy's got an LDL like a whopping 192, an HDL of 40, and triglycerides of 180. Oh, he's got severely high LDL, very, very high. He's got low HDL, and his triglycerides are greater than 150. So he's kind of definitely elevated triglycerides, but it's not like crazy, crazy severe like it was when we said it would be greater than like 200, greater than potentially 500. So he's definitely pretty bad triglycerides, but even way, way higher LDL. Now, if you guys remember, we can do something called an atherosclerotic cardiovascular disease risk calculation to determine if it's greater than or less than 7.5%. You fill out sex, you fill out age, you go through race, you put in your total cholesterol, you put in your HDL, you put in your systolic blood pressure, fill out your personal history, boom. And then once you do is you get a calculation here and it gives you your actual risk. Let's see what this guy's was. If we do his ended up being what? Holy crap, 53%. So this guy has got insanely high LDL, clinical atherosclerotic cardiovascular disease, and his risk is greater than 7.5%, and he's also 70 years old. So he's greater than, he's like within that 40 to 75 year old range. So he's got a lot of issues here. What else? Does he have any evidence of hepatic steatosis? We get the LFTs, it did show that they're elevated, and then we get a liver ultrasound. He's also got hepatic steatosis. So this guy has got skin findings, hepatic steatosis, clinical atherosclerotic cardiovascular disease. My gosh, and a risk that is super high. Okay, well, how do we treat this guy? First thing, he needs to have dietary changes. He needs to stop smoking. He needs to lose weight and exercise. So that's the key thing. But more importantly, somebody get this man a statin, okay? He needs statin therapy stat. So you guys remember the indications for statins? Remember, it was if they have clinical atherosclerotic cardiovascular disease. He probably should have been on this from the get-go. He has had a TIA. He has coronary artery disease. Boom, that's definitely an indication. So he needs high intensity. He's not greater than 75, so he wouldn't kind of fit that moderate intensity. He definitely needs high intensity for sure skis. If that isn't enough, guess what? He's got an LDL of 192. That's greater than 190. That's an indication for high intensity. He also has diabetes. He's 40 to 75 years of age, and his atherosclerotic cardiovascular disease calculation was 53%. Oh my gosh, that's definitely high intensity. And even if that wasn't enough, just itself being greater than 7.5%, it's high intensity. This guy needs a high intensity statin. So start him on a atorvastatin, 80 milligrams, once a day. Now, remember, how does that guy work, and what kind of labs and what kind of things should we be monitoring for, like side effect wise with this? Remember I told you that the big thing is it interacts with other drugs, so it's a CYP450 type of interactions. The other thing is it can cause a lot of myopathies, potentially rhabdomyolysis, so a bump in CK and muscle pains and aches. And it can also cause hepatotoxicity, so it can also cause a bump in your LFTs. So do LFTs and then watch for any kind of muscle pains. Maybe check like a CK level if you're concerned that they have rhabdo, especially being on a high intensity statin, a high dose like this. What's the mechanism? How does this one work? It's an HMG-CoA reductase inhibitor, so it inhibits the synthesis of cholesterol. So that's important to remember. And then what is another drug that, because he has high triglycerides, statins are good for being able to potentially lower your triglycerides, but they're primarily good at being able to lower your LDL. What would be another drug, do you guys remember from that chart that we talked about, that's really good at being able to lower triglycerides if the LDL, and if the statin isn't able to lower the triglycerides enough? What other drug could we add on? It actually works to potentiate the lipoprotein lipase enzyme. Do you guys remember? Your fibrates, okay? But that would be it for this guy, and I think we took care of him. Hopefully, after we do all these things, he gets a little bit better. Got to work on that stuff, buddy. But engineers, I hope that made sense. I hope that you guys liked it, and as always, until next time.